You want to start?
Yeah, we are live.
Sure.
All right. So good evening to you all. I welcome you all again to another of our slide seminar session with Dr. Borges. The title of today's slide seminar is called Cogito, Ergo and will be presented by Dr. Anita Borges, the lab director and consultant pathologist at Center for Oncopathology, Mumbai. So as you now well know, that in the slide seminars, we invite 4 residents to take part in the slide seminar, which will simulate a live over the microscope teaching. So for that, today we have Dr. Maharshi Devnath. He's a PGY 3 at RIMS Imphal. Dr. Nilanjali Jain, a PGY 3 at GMC Bhopal. Dr. Gunjandeep Kaur, PGY 3 at GMC Amritsar. And Dr. Yewe Min, he is a PGY 2 at University of Medicine 2 at Myanmar. And the session will be moderated by me, Gaurav Chatterjee. I'm an assistant professor at the Hematopathology Lab here in Tata Memorial Center, Mumbai. And the webinar is hosted, as always, by Dr. Sumit Gujrat. So the structure now you are well familiar with. Dr. Borges will directly interact with Maharshi, Nilanjali, Gunjan, and Yahweh. And you, the larger attendees, you can ask questions. So we encourage you to ask questions in the chat section and take part in the poll questions. So I will bring those doubts to Dr. Borges and she can answer your questions. Some of our routine disclaimers. Few more, and importantly, because this is a slide seminar, all the digitized slides are proprietary property of the presenter and any unauthorized reproduction of the same is not allowed. So with this, I think we are ready to start our today's webinar, Cogito Ergo Sum. I will hand over the stage to Dr. Borges.
All right. Good evening. Yeah, good evening, everybody. I think I'm always energized when I have to do these slide seminars, when I see these young people. You all have to remember that I was young once upon a time. Huh? So I didn't get where I am without being young. That's for certain. And let me tell you that I was also once upon a time, sort of my teachers and, those who were seniors, we all had to learn from them. So I also did the same. And I just hope that every one of you is going to enjoy this. Now, I'm sure that you have heard of, or you have attended some of my slide seminars. And I was just telling these 4 young people over here that it's not something that you have to just attend. You have to actually learn. And to learn, you have to take an active part in what is going on. Now, it is not possible for us on this kind of platform to ask questions to everybody in the audience. And that's why you have representatives of the student community, and the 4 of you are there to answer questions, also to ask questions. And there, of course, lots of questions will come on the chat box. And I think I would be very happy if I know the answers to those questions to answer them. Yeah. And some of them that I don't know, I will find out and let you know at some time. All right. So now today's, the title that I have given this is something that is a quotable quote. It means lots of people quote this. And this was, this mathematician, he was a French mathematician and philosopher whose name is René Descartes. The French have a funny way of not pronouncing every letter that they write. So it's not Descartes, it is Descartes. That's French for you. I can't say anything more than that. English also is peculiar in its own way. And I think, we have the Devanagari script in India, and that's good because you pronounce it exactly the way that it's written. Sometimes I find out the way of pronouncing a word that is written in English. At least I did when I was a kid, by reading how it looked like in the Devanagari script. All right. So now the quotable quote is Cogito ergo sum, and it translates as I think, therefore I am. Okay, so before we start the slide seminar. Would somebody like to tell me, or we can have a poll on this thing? What is the language in which this quote has been spoken? So what is the language of this quote? And I've given you some options. Is it Italian? Is it French? Is it Old English? Yes, there is something called Old English. English has over the years evolved, no? So if you took English in the 12th century or even older, the English didn't sound like what we speak it now. Or is it Greek? Or is it Latin?
So
Yeah, anybody? Come on, one of you guys. Marshi, you want to take a crack at this?
I think it's Latin.
You think it's Latin. Very good. What about you, Yahweh? What? This is René Descartes. He was French. That means his nationality was French.
So we did run the poll, ma'am, and 58% of the people believe it is French, followed by 20% who think it is Latin.
All right. So, and how many people thought it was Latin? Sorry, how many people?
20%, ma'am.
20%, and 50% thought it was French. Obviously, it is not. It is Latin. Okay. Now, so why did this Frenchman write a quotable quote or speak a quotable quote in Latin? Anybody? Yeah, we had Marshi who guessed, or at least he knew, right? He said Latin. So can you tell me, Marshi, why did this guy who was a Frenchman, why did he use Latin? Any idea?
For worldwide publication.
For
of his book. Worldwide publication of his
worldwide publication. Yeah, in those days it was not worldwide, and he may not even have necessarily published it. But yes, when you spoke or you wrote on a scientific subject or a philosophical subject, then you used Latin. Okay, so that's the reason that this man who was he was a great mathematician and he was a great philosopher. When he was thinking about what is it that makes us us, in other words, what's the difference between me and a plant, or between me and a chimpanzee, and between me and any other living thing on this earth? And he came up with this quote: I think, therefore I am. Not only that, how do I know that I'm alive? That is also another thing, right? So his way of looking at this whole question is, I think, therefore I am. That means if we don't think, if we are not thinking human beings, then perhaps we are not human at all. That was the purpose of his philosophical statement. All right, now we've finished that. I think I want to give a little introduction to the essentials of a learning experience. I was talking to some of these four young students just before we went live on air, and I think that there are these three essentials of a learning experience, and I call it a learning experience because I am not here to teach. I am here to help you to learn. And if you wish to learn, you have to take an active part in this learning. And learning is truly an experience. You have to dissect the different parts of learning. And I have believed for a long time that there are three essentials of a learning experience. And the first one is curiosity. Yes. The second is using reason. You must use your reason. And the third one is you have to learn how to use judgment. In other words, when is it appropriate to use reason and when this reason may have to be altered. And we'll see there's some experiences or some lessons that we can learn from any case that you have to see, and all cases are a learning experience. Now, what is this curiosity? You know, there are two words again that I feel are often conflated. That means they are used interchangeably. And that is education and training. Okay? What do you think that you are here for? Are you here to be educated or are you here to be trained? Come on, Neelu. Yes, Neelu?
To be trained.
You are here to be trained. All right. What about Gunjan?
To be trained.
To be trained. Yahweh. You know, could you hear me, Yahweh? I
Yes.
said, yeah, education and training. So are you here to be educated or are you here to be trained?
Educated.
Educated. Very good. What about you, Marshi?
Ma'am, to be trained.
To be trained. Now, the only person who said educated is Yahweh. Yahweh, do you want to tell them why you don't think that you are here to be trained and that you're here to be educated? Tell them.
I use that at the thinking way.
Sorry?
I use that the thinking way.
So you think that education teaches you to think. Okay. So what does training do? What does training do? Because they want to be trained. Yes, Marshi, what does training do? Maybe you never thought about it before, but I'm asking. So what does training do? Because all three of you want to be trained. And Yahweh said that he would like to be educated because an education teaches you how to think. So now. Yes, Marshi? All right. Well, I told you that these two words mean different things. They are not interchangeable. And the reason is that training tells you, or maybe even teaches you, what to do and how to do. And that's what the three people who want to be trained want to be taught. They want to be told how to do and what to do. Whereas what Yahweh said was he wants not just to know what to do and how to do. Okay, that a robot can do. Yeah, I can train anybody to do something. But if I really, really want to do whatever it is that I am set out to do, and particularly something professional, then I have to ask myself why. I have to question everything. In other words, I have to learn how to think. Okay, and when you ask, I'm asking you, how many of you, when you read a textbook, or now when you're listening to me, is your mind actually asking why? No. You are here because you think you will be told what to do and how to do it. And that is not why you are here. That is not what you go to a medical school for. It's not what you went through all your, what you say, educational experience. If you went there to be trained, then you are not educated. And to be educated is really what you should be trying to achieve. And if you have curiosity and you have a real passion for curiosity and you keep asking all the time, why, you use reason in its appropriate place, and rules, reason is rules, evidence, guidelines, whatever. And you noticed over there you use these rules, but you use them in the appropriate manner, in a context, then you are really educated. Okay, because you cannot take a rule and just apply it. That's what all computers and all robots do. They learn a rule unless you are dealing with artificial intelligence. Okay, so if we want to use our intelligence, then we are being educated. Yes, I see lots of people talking about education. There's somebody like Pooja Garg and somebody like Navata and somebody like Shefali. They all want to be educated. So now you guys, you may want to be trained, but my job is to educate you. Okay, now let's see if I'm really going to do that. Now, what is this curiosity? And I really believe curiosity is one of the most important things if you are wanting to learn. Yeah, it is really a strong desire to know or learn something, and we have always had curiosity. Curiosity about all sorts of things, and particularly when you're in college or you're in school. What are you doing? Who's going out with whom? I see those two people over there a lot of the time, and you're curious to know what's going on over there. Yes, that is curiosity. But I think that when we are doing a professional education, we have to be curious about this. Otherwise, you're never going to learn. You will never learn what's going on with two people who are holding hands unless you are intensely and passionately curious to find out, right? So we should bring that same curiosity to our learning every day. So there's a strong desire, translates, I think, as a passion. You must have passion, because without passion, learning is difficult. And I've said this before. Many of us, particularly in pathology, come to pathology because we didn't get some other subject that we wanted to do. Okay, can I just ask you, Marshi, did you always want to be a pathologist? Be very, very open. Did you want to be a pathologist? No. What did you want
First
to be?
choice was
You wanted to be what?
radiologist.
Radiologist. Okay. Yavi, what did you want to be? You always wanted to be a pathologist, Yavi?
No, I wanted to be an engineer.
You wanted to be an engineer. How did you end up in medicine? Wonderful. Okay. Yeah, now what about you, Gunjan? What did you want to be?
I'm a gynecologist.
A gynecologist. Okay. And you, Neelu?
I'm dermatologist.
Dermatologist. See, there's not a single one of you who really wanted to do pathology. But whether you liked it or not, now you have ended up doing a course in pathology, and you may be disappointed because you didn't get you didn't end up doing what you wanted to do as a profession. But that does not mean that you should just do it desultorily. Yeah, whatever you do in life, please do it with passion. And this, I think, to have this curiosity, whether you were a radiologist or a gynecologist, or you were an engineer, or you were a dermatologist, you would have become the best, whatever it is, if you did it with passion. Now, you didn't come into pathology with the same passion, but develop it. Keep at this, and then you will realize how wonderful this particular pathology is. I'm telling you, it is the basis of all of medicine. There is no doubt about that. Of course, you've got other things like anatomy and physiology and whatever. But to understand disease, you understand pathology, and realize that we are so privileged to see and to understand what other people only have to imagine. A surgeon has to imagine, what is going on at the level of the tissues. So also, even a radiologist has to imagine what's going on at the level of the tissues, and we are privileged to do this. So every day when you get up, Okay? Get up and say, I am the most privileged person in this world. I mean, as a professional, as a doctor, because I can see, I can feel, I can actually understand what is going on where other people have to imagine. Okay, I see somebody here called Humera Beg, wanted to be a pathologist since UG. Very good for you, Humera. If you wanted to do it, then you have got one step ahead of everybody else because you had the passion. Okay, very good. So that is curiosity. Okay, now this, we've said that it is a strong desire and all that thing. And you see this, what is this thing on the top that you see over here? It tells you that we have gone from being Australopithecus, yeah, the southern ape, to becoming Homo sapiens. And we are Homo sapiens, the ape that thinks. And so Yahweh was right. We are ones who can be educated, not just trained. I can train a horse, I can train a monkey, there are people who have trained cheetahs and lions, and you know that elephants are trained. Okay? But we have to think. Of course, we named ourselves Homo sapiens, the ape that thinks, but that is what we are, and that's what we have to be. And a desire for knowledge is, in a general sort of sense, is a basic characteristic of Homo sapiens. We're always wanting to find out how something works. What is it about nature? Why do clouds form? Why does it rain? Why do you think elephants and all these things, maybe they do, even dolphins maybe, or something, they are intelligent creatures, but do you think they have reached that stage of intelligence that our big brains have given us? The answer is no. We really want to know, and that's why we have science. We want to know everything about our environment. Yes. So, and this is something that you should carry with you. And this was said by Albert Einstein, only he didn't say it in Latin, he said it in English. Okay, maybe he said it in German and it has been translated, I don't know. He said, I have no special talents, I am only passionately curious. And if Albert Einstein, who is a genius, could say that, I think we can take a little bit of a lesson from what he said, and try to be as try to reach for the sky. Okay, that's all that I can tell you. Okay, so what is this curiosity? I told you it is curiosity about what, curiosity about how, and more than anything else, it is why. And this why question, and you have to ask why, is what drives diagnosis and learning in medicine. Please never forget that. It is not only about making a diagnosis. All right, so now I will just quickly tell you what I think is the way to arrive at a histological diagnosis. And this is the essentials of any diagnosis. You need good observations, and these are positive and negative. It's not always easy to know what is a negative observation, but that comes with practice. If you have, say, seen a salivary gland, say the submandibular salivary gland, and you've seen it many times, and now you are seeing a submandibular salivary gland maybe after the umpteenth time, and it looks benign and it looks okay, but suddenly you realize, hey, this is odd. Where have some of the acini gone? Now that's a negative observation. You don't see the acini. And then you put your finger on it and say, hey, if the acini are gone, why have they gone? And then you ask that question, and you will come to some understanding that there was some atrophy over here. And from there, you will go perhaps to the etiology of this atrophy. But if you say, okay, it's benign, there's no particular diagnosis that I have to make. So positive and negative observations. And negative observations are more difficult than positive observations because you have to notice that something is missing. Okay, and you can only notice that if you have got a good understanding of what is normal. Okay, so you have to interpret those observations. Then, of course, you must have the context, which is the history of the case. Analysis, which is a function of intelligence. All the observations, all the interpretations have to be put into the context of the history of this thing, and then you have to make some kind of analysis, and that's what we do every time we do a differential diagnosis, because we've made observations, we've interpreted those observations, we have then looked at the history, and then we come to 2 or 3 diagnoses. How did we come to those 2 or 3 diagnoses, or maybe 1 diagnosis? Because we have analyzed the situation. Okay, and that is what is intelligence. That's exactly, as I've said it again and again, what the CIA does. What is that? What is that intelligence? They're not all high IQ people in the CIA. The Central Intelligence Agency. And what does the CIA do? It sends its spies to make observations, then they interpret the observations, they put it into a kind of context, and that analytical function is called intelligence. And our counterpart in India of the CIA is what? Yes, Marshi?
RAW.
We have a counterpart, right? So what is it?
RAW.
RAW. So what is RAW?
Research and Analytic Wing.
There you are. Research and Analysis Wing. Exactly what I said. Research is what? Making observations, sending out, getting information, interpreting all of this, and then in an act of intelligence, and that's why these are known as the intelligence services. That's the meaning of intelligence. It's an analytical function. Then you can add additional things like an appropriate investigations. You come to possible diagnoses, then you narrow down the diagnoses, and you come to a final diagnosis. Excellent. So essentially, you need a good description, which is observation and interpretation. And this is the crux of the problem. If you don't make a good description, you are not going to be able to analyze what you are supposed to analyze. Yes? So, and this means you have to be familiar with normal histology and its variations. It's absolutely essential. And I'm telling you, not anybody, and I say this with full emphasis, nobody has the right to go and to make a diagnosis on any slide or any histology unless you know what normal is. Okay, so if you're looking at a gastric biopsy, or you are looking at a brain biopsy, or you're looking at anything, first you have to know what normal is. And if you have never even looked at normal or even brushed up your idea of what is normal by looking at a histology textbook, you have no business to be doing this. Okay, because this is onerous work. We're not there fooling around, trying to make diagnoses. So you must know what is normal. Yeah, because as I said, you cannot evaluate the abnormal without comparison with the normal. You have to learn to use professional terms. And those professional terms is the language that we pathologists speak and understand. And if you use professional terms in a description, then it helps by triggering thoughts. The moment you say a word like palisade, yeah, you are seeing something over there. But when you say this is a palisade, you have to say it in your head, because there's not always going to be somebody there to listen. Nobody's going to ask you what it is, because we are all here to one day go out into the real world and do what we are doing. If you say the word palisade, a certain thought is triggered in your head. A certain interpretation comes to mind. Okay, so just looking at it is not good enough. So it helps in triggering thoughts. a good description, and I have highlighted it here in green, is one, and mark my words, will allow an experienced individual like myself, I have reasonable amount of experience, to render a diagnosis without having examined the slide. So if I have a good pair of eyes, that someone else will be my eyes, and if you have given me a description that is so good, I will be able to make a diagnosis that is a good description. Okay, so as I've said in the next, a good descriptor will make a blind man or woman see. And every time I have 4 of you guys over there, I am looking, it's like interviewing candidates to be my eyes in case I am go blind and I still want to practice pathology. I don't think I want to practice much pathology again, but I am interviewing you guys to see whether you will be able to describe for me things in a way that I would be able to make a diagnosis, because I've seen a lot of pathology. And if you describe it so well that I can see, then that is what I would consider a good description. Okay. And so how do you do this in your everyday thing? I can't be there everywhere. So what you do is you practice describing a slide to yourself, okay, or your friend. You can't describe a slide to yourself which you have not seen. Okay, but you have to practice describing slides to yourself anyway, because you have to learn how to use these words, okay, that are important to trigger thoughts. But you start describing slides to a friend who has not seen the slide, okay, and so you sit at your microscope and you tell the person to sit at the other end, can't see the slide, and you describe it. And when you describe it, if that person is able to make the diagnosis, then your description has been good. And you can practice this again and again. Everybody has got friends and colleagues in the department, and that is what is a good description. And then we know that you're not just matching pictures. That's very important. All right, so what is this language that pathologists speak? And it is descriptive terms in histopathology. Okay, and these descriptive terms are important. You use the term epithelial, epithelioid. I can't describe them all now because that's not the purpose of this thing. But why? What is it that I call epithelial or epithelioid? What is it that I will say is mesenchymal in this descriptive? What is small blue cell, round cell? What will I call a cyst or a pseudocyst or a rosette or whatever? Now, these are all terms. I can't put them all here, but you should know what they mean. You cannot speak this language and speak it to somebody else. It's like if Yahweh talks to me in Burmese, I won't understand a damn thing, okay? Because I am not familiar with these terms. So why do I need to be familiar with all these terms? A, to be understood. B, to understand. And why? If I'm using the word pleomorphic, what is it that you understand by the word pleomorphic? Yeah, that's important. If I'm using the word fibrillary, do you understand what it means? So if you're reading a textbook, for instance, and that textbook says polypoid, what do you understand by that word? And would you use the same term if you were describing something? Now, I'll tell you about polypoid. The other day I was with a group of students, okay? And it was a frankly polypoid tumor. And I said, what does polypoid mean? And you know what I was told? That it was an outpouching. So you have not understood what is a pouch. You do not know what is an outpouch. And if you said, and I close my eyes and you say you can see an outpouching, what do I imagine? That it is like a diverticulum, right? It was not a polypoid thing. So you have to learn the meanings of this language that we speak so that we understand each other and not misunderstand. what we are doing. All right. Now, there are whole lots of patterns over here. I told you, nest, fascicle sheaves, herringbone, all these sort of things, which we should know what they are. And the purpose of a slide seminar is, as I told you before, not only to make a diagnosis, but to understand what is this language. So in a slide seminar, I try to ask you to describe things, because when you describe something, you are triggering thoughts in your own head. Okay, next, let us go. Right. Now, how does one improve one's diagnostic skills? Those of you who have been attending, I always say that at low power, you have to ask yourself 5 questions. Number 1, is there any normal tissue or structure present? Number 2, is there an abnormality seen? Number 3, because every time people think, why is this stupid question? Is there any abnormality seen? Can any one of you tell me, why should we notice whether there is an abnormality seen? Is there any normal structure? All right. You know, we want to know, yes, they have said it's buccal mucosa. Can I see squamous epithelium over there? And it isn't a mix-up. It hasn't come from the testes or somewhere else. Okay. But why should we ask this question? Is there an abnormality seen? Any one of you? Yes, Neeru? Why should we ask this question? No? Yeah, Gunjan, why? Why should we ask this question?
And because it's important to identify if there is a pathology or not.
Why?
And
Why is there to identify whether there is a pathology or not?
So we can identify the area where we should
people biopsy non-pathological lesions. Do you think that anybody will biopsy something that does not have a pathology?
To identify an organ.
That is normal structure.
Yes,
I'm
ma'am.
talking about number 2. And we are asking, is there an abnormality seen? Do you think anybody will biopsy something that is not pathological? Marshi?
No, ma'am.
Then why should we ask, is there any abnormality seen? It should be abnormal, right? Yes, Yahweh? Hi. I've got some answers in the chat box.
Oh.
It says treatment differs for diagnosis. But somebody called AT, I don't know who AT is, says the answer which I expected, and that is to ensure that the area of interest has been sampled. Yes. So somebody has got a lump in the breast, and it happens to be a carcinoma, but somebody put in a needle and biopsied an area that was adjacent. So are you not interested? And what would we call it? What do you see if somebody has put in a needle and found breast tissue? What is the diagnosis that quite often goes out? You know what it goes out? You'll see a little cyst somewhere, you'll see a little fibrosis somewhere, which is perfectly normal. And what will it be called? It will be called fibrocystic disease of the breast. And we have made up a diagnosis. Yes. So it is very important to not make up diagnoses. We make up diagnoses every time an appendix is removed and call it chronic appendicitis, because most of us don't have the courage to say that this is a normal appendix. Yes, there is no such thing as chronic appendicitis, let me tell you. So we make up diagnoses because we assume that everything that is removed because it is abnormal. Okay, so whoever the AT was is good, and yes, and some people are saying inadequate sampling, some people are saying representativeness, and so on and so forth. So that's right. So please ask yourself this: is there any abnormality seen? Then, of course, you have to know what is the relationship of the normal to the abnormal. All right. If you've got a biopsy, or you've got a lesion in the skin. Now, what do you mean by relationship of normal to the? Is this lesion in the dermis? Is it attached to the epidermis? If it's in the epidermis, is it actually arising from the epidermis? Has it gone down into the subcutaneous tissue? So there is normal subcutaneous tissue, yes. There is an epidermis on top, but the relationship of this lesion is, it is epicentered in the dermis, suppose. I mean, I'm just giving you an example. And that it is not in any way in contact with the epidermis, etc. So this is very much a part of perspective. Perspective is when you look at something from a distance. So you get a cone-shaped view, which you can't get if you go to high power straight away. Okay? And I am my hearing is very acute. So I know when a student is sitting next to me and I hear tuck, 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 tuck. You know, when they put a slide under their microscope. And what are the 4 tucks that have gone on? Huh? There is times 4, times 10, times 25, and times 40. And in no time at all, it has gone. In less than a second, it has gone tuck, 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 tuck. Okay? Because they have not stopped at times 4, that is 4x, to get a perspective on what they are seeing. And that's what all students do, and you have to get out of the habit, because very soon you are not going to be students, you are going to be in the real world, and there is no substitute for low power, because it tells you about the relationship of the normal to the abnormal. Of course, it tells you everything about whether there's normal structure present and normal tissue present or not. And is there a pattern to the abnormality? Because you can see patterns at low power which you may not be able to appreciate at high power. You may appreciate a secondary pattern at high power, but a primary pattern you will be able to see at low power. And then comes the last of these things which you should be doing, which you do literally in a millisecond, as far as I can see. Tuck, 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 it goes. That is where should I direct my next power examination? Usually your high power examination. That's the last thing that you should be doing. You should be asking all these questions. And then now, what do you do at high power? You all know, because you do it. You need cellular characteristics, size, shape, whether this whole thing is monomorphic, polymorphic, pleomorphic, is there anisocytosis, what's the cytoplasm like, and we should be systematic about it. Cell membrane, color, type, intensity, which never happens. I'm never told size, I'm never told shape, I'm never told about the cell membrane. Straight away people go to the nucleus. And then I'm told that the cell is round or oval. And what people are describing is not the shape of the cell, which is very seldom round or oval. It is they're describing the nucleus. And this is a shame again, because you are not building any kind of picture in your mind, okay? You are just doing this for the sake of description. You're not trying to build good observations and good interpretations of those observations, okay? So we won't waste time. Now here is a schema, okay? And this schema is how do you integrate description and context with analysis? And we do this in our everyday lives, or we did it when we were doing clinical medicine. You always asked yourself this question, and we should still ask ourselves these questions. When I have made all my descriptions, I have made the observations, I have made some interpretations, and I'm doing an analysis, I have to ask, yeah, is this congenital that I'm looking at, or is it acquired? If it is acquired, is it physiological or pathological? If it is pathological, is it neoplastic or non-neoplastic? If it is neoplastic, is it benign or malignant? And if it is malignant, is not what type, is it primary or secondary? Yes? And if it is, that's if it is neoplastic. If it is non-neoplastic, then what do we ask? We have to ask something. And what is it? Which of the general pathology chapters, apart from neoplasia, does this particular lesion fall into? Is it cell injury, cell death, and some kind of adaptations? Is it acute and chronic inflammation? Is it repair, regeneration, healing, fibrosis? All this should come into your head. It should come as a, and not just, where did I see this before, and let me match the picture. This is how one does a logical analysis of what it is that you are seeing. Just as on the neoplastic side, you ask, is it benign or malignant? And then ask if it is malignant, whether it's primary or secondary. There is a way, an algorithmic way of finding out. So is this what I'm looking at? Is it metabolic disease? Is it an immune system disease? Is it a vascular disorder, etc.? And then come to a final diagnosis. Okay, so now we come to the cases. They're very simple, and that's why I thought I would take some time to get to this thing. Now, who's going to take the first case? I see you all in a line over here, and Mershi is first, and then comes Yavi, and then comes Gunjan, and then comes Neelam. Neelu. So we can start with Mershi. Come on. Now here is your, you can read this out, Mershi, loudly.
Case number 1. Please examine the slide and determine the age and clinical history.
You notice I didn't ever ask for the diagnosis, right? Yes?
Yes,
Oh, good. So now let's go to the next thing. Yeah, come on.
It's a low power view.
You know how you can use a pointer, how you can everything. Yes. Is that okay? You know, yes, I'm going to turn this whiteboard on. And 1 minute, I think you moved. I can't shift this. Let me see if I can. Yes, yeah, that's fine. Okay, so now.
In the low power view, we can see no normal tissue, mainly the abnormal tissue, and it's a capsulated area. The tissue is capsulated, and in the abnormal area, we can see mainly some tubular structures having some eosinophilic luminal contents and area of hemorrhage. And below the caps.
1 minute, Mershi. This is low power, and you're describing what you're seeing right here at low power, right? And you said that there is no normal tissue. I agree with you that there is no
normal tissue.
Normal tissue.
And one capsule is seen, and some tubular structures are seen. And
let me go back. Please examine the slide and determine the age and clinical history. Yes, and you are now trying to make observations. Yes, Marshi?
Yes, ma'am.
Very good. Now, you are telling me at low power, and you have a question that has been asked to you, and you are telling me that there is no normal tissue. How do you know what normal tissue you had to expect over here? This was from the buccal mucosa, this was from the kidney, or this was from the brain, or this was from any such area that you can tell me I don't see any normal tissue. This is low power. Now you tell me what you are seeing at low power, and don't tell me that you are not seeing normal tissue, because you do not know what tissue to expect. Everybody agrees with me?
Yes, ma'am.
You agree with me?
Yes,
excellent. I knew when I said these are the 5 things you have to do at low power. When you see a slide, you will say, but What was the question that was asked to you? You don't know what this tissue is, my dear friend. Yes or no? So now will you please describe this thing?
Yes, ma'am. At the low power, you can see encapsulated. Yes, ma'am. The tissue is capsulated. We can see one capsule, and it contains many tubular structures, which contains some eosinophilic contents in the lumen.
I don't think I can see that. Can anybody see contents in the lumen? No. You know what Marshy is doing? He has seen the whole case and he's written down something on a yes or no, Marshy. You've got a little book by your side or a pad or something on which you have written something, Marshy. You have or you have not?
No.
What's the answer to that question? Yes?
No, ma'am.
No? Okay, so you're just looking at this, right?
Yes.
Okay, it's all in your head. So I don't think I can see any contents in this. So you said that you saw some
Tubular structures.
Tubular structures. All right. Now.
And some area of hemorrhage.
All right, you have an area of hemorrhage. Now, tubular structure. Are you satisfied? I told you something, Marshy, that you are now, all four of you are being interviewed to be my eyes. Okay? So, do you think that I can see tubular structures is enough of a description that I am being able to see what Marshy is?
Tubules are in various shapes. Some are rounded and some
are rounded. Now, Marshy, I want you to show me the rounded shapes, because you said some are rounded, and when you say some are rounded, you mean that's what hits your eye immediately. Yes. There's an ambulance. Yes, Marshy. So he's got one rounded structure. Yes. So how many are you going to find like this that are rounded, Marshy? The majority are rounded?
No, ma'am.
No. So why did you say rounded? So what kind of tubular structures are these?
Some are oval and some are...
Can I request you all to be muted when you are not spoken to, please? Yeah. Thank you.
Yes, Marshy?
And some are round, some are oval, and
some are oval. Now, please, Marshy, show me an oval one. I can't clear from here because I think their pictures, Gaurav, their pictures are on top of the clear thing, but maybe you can clear?
Yes, I will.
So clear this. Yeah, then I can see clear. All right. Yes. So now show me an oval one. Now he's picked one oval one. Yeah, good. Can I ask, because the next person over there is Yahweh. Yahweh, can you tell me what, if you had to describe these tubules, and he has used the right word. He has said that these are tubules. Excellent. Now, can you tell me how you would describe these tubules?
There's a tubular structure with various sizes and shapes.
Various sizes and shapes, yes. But the majority are?
But the majority of tubules are straight.
They're straight? Yes, Gunjan?
The majority.
Oh, sorry, yes, okay.
The majority of...
Huh? Yes? What? Yeah, Gunjan, tell me, how would you describe these tubules?
And most of them are elongated.
Correct. Most of them have been cut in the length, right? Yes, so they are cut in the length, they are elongated, and many of them have, what do you call all these? They are, can you not see them? They are elongated, yes, but several of them have got comma shaped or double S, right? Are they not? So there is an S or a comma or some other shape. Okay, when they are cut transversely, you see them as round, or if they were cut somewhat obliquely, you see them as ovals. But the important thing for somebody who's not looking at the slide is to say that it's not just round or oval. Okay, they are elongated and yes. So you have made a three-dimensional image in your head. So these must be coiled because they have comma shapes and they have some S bends in those tubules. Yes or no? Yes. Very good. So now continue with your description.
Yes, ma'am.
And yes, so you can see the outlines of those tubules.
Yes,
and you see a lot of hemorrhage. And the hemorrhage is it subcapsular or is it what?
Away from the capsule.
Correct. So now you can see a capsule, then underneath that you see these tubules, and then you see hemorrhage. Now, I am listening to this and I see that this is a capsulated organ, encapsulated organ. It has tubules which are coiled, yes, and that there is hemorrhage that is deep to this, just underneath the capsule, which you might wish to even think of as this may be a cortical part and then a deep part, right? But so I am thinking, when you describe this, is this the kidney? Because I've got two things in my head now. Is this the kidney or is this the testes? Because there's no other organ that has coiled tubules. Yes or no? And also has a capsule. So now if you want to give me an idea of what this is all about, you would say one negative finding. It says there are no glomeruli. Yes, there are no glomeruli. In fact, in your head, that should be part of this description. Yes or no? Yeah. So this is not the kidney. That is something that should come as part of your interpretation, and therefore this is most likely to be the testes. Excellent. Very good. Now, anything more you need to say at this part? No, but you can see something else at this part, which you should have said. You told me about the tubules, you told me about the hemorrhage. Anybody else wants to add something?
The stroma.
The what, sorry?
The stroma or the interstitial tissue.
The interstitial, all right. Anything else? You made up your mind, no, that this is testes. Does this look like normal testes? And if you don't think it is like normal testes, what is missing that tells you that this is not normal testes? It is a negative finding, and you can see it at this part. Forget the glomerulus now. What is that negative finding that you see at this part? What? Hey, there are no nuclei. Come on now, if this was the testes, it should be full of nuclei. Yes or no?
Yes, ma'am.
Yes, ma'am.
So now you know what is the meaning of negative finding. A flag should have come up immediately. Hey, this is all pink. Where is the blue? That's what you expect to know. Do you know any structure anywhere in the body that will not have blue in it? No, that's why we use hematoxylin, right? We use hematoxylin because we want to look for the nucleus, and there's not a single nucleus. So Then the next question comes to your mind, why are there no nuclei? Now you understand? Curiosity, negative findings, why? Why are there no nuclei? All right. So the question is not just about making a diagnosis, it is about noticing things that help you in the end to make a diagnosis. Yes, okay. So now come on, describe this. Now you can see the tubules at higher power.
Yes, ma'am.
Yes, what is it now you see?
In this power, the tubules are seen. There are also in various shapes. Some are elongated, some are round, some are oval. And ma'am, some little hemorrhage can be seen below the capsule. Some hemorrhage can be seen below the capsule. And the interstitium, there will be a little bit edema.
Yeah, well, yes. So there is edema. Otherwise, in a testes, everything is, all the tubules are closely packed. You should not be seeing much in the interstitium at all, right? So there is space that is in between here, and you have interpreted that space as edema. So you see, an observation is that there is space between the tubules, which you should not see in a normal, and the interpretation is that this is probably the result of edema. There can be many reasons why there is space. It could be that tubules have dropped out, but it doesn't seem like that, no, because it is a light pink sort of thing. Very good. All right. Now, what is this?
Yes, ma'am. In this area, you can see lots of blood vessel, congested blood vessels.
Yeah.
And interstitial edema also. And
congested blood vessels. Now, is this the aorta?
No, mainly some are vein and some artery also.
There are some veins and then there are some arteries. How do you know that these are veins and arteries? Which are veins and which are arteries? Come
on. This is vein.
Yeah, you take your, so that is what?
Vein.
That's a vein. And?
This looks like an artery.
Which looks like an artery, show? That one looks like an artery. Why?
This one looks like artery.
So there are so many arteries that you're seeing around. What do the rest of you think?
And this also looks like artery.
Right. Now you know that you're looking at the testes, right? Yeah?
Yes. Yes, ma'am.
How many arteries do you normally see in the testes?
Ma'am, the large arteries and veins mainly seen in the septa, fibrous septa. And
in the large arteries and veins are seen in the septum. All right. So, and what do you think is there in these thing? What are these? Oh, sorry. 1 minute.
These are.
What is this? What are these?
These are small blood vessels.
Yeah, small blood vessels. Now, please tell me, what are they? Small blood vessels doesn't tell me anything.
The venules.
Yeah. So what have you got? You have got, I mean, there is one thick walled vessel over here, but I don't have any indication that this is a artery or this is an artery, okay? All of these seem to me to be congested venular or venous structures. Yeah. Now that is very interesting. That you have got congestion in venous structures over here. Most of them are venous structures. Some of them, as somebody called, there are so many people who have been sort of texting on this chat box. They've been saying that this is a plexus of veins, a venous plexus, veins, muscular veins. And yes, you can see them. There is a few of them, or the congested ones are seen within this parenchyma. Much of this is outside of the parenchyma, no? It seems that this section has probably gone somewhere close to where the veins are leaving this testicular parenchyma. Okay. Now, will you tell me what these are? These other structures over here, which I can now, I'll clear this and then I will point them. What are these things? These structures, they looked different, right? From those seminiferous tubules, and we'll see them in the next slide. But anybody would like to? Yes?
Epididymis.
Epididymis.
An epididymis that is there, and that is where you have the epididymis or something that is close to the rete, where you have the hilum of the testicle, which you are getting all this. Now this is quite different from what we were seeing over there. Yes, come on, tell me, what do you see over here?
These are the seminiferous tubules.
Yes.
Which contains almost necrotic.
They're almost necrotic. What do you mean by almost necrotic? What more necrotic do you need to say that they are necrotic?
These are all necrotic.
Huh?
All necrotic.
Necrotic. What kind of necrosis is this?
This looks like coagulative necrotic.
Coagulative necrosis. Okay. So there is coagulative necrosis, and these are seminiferous tubules. Yes, very good. So, and there is, and now when you look at the interstitium, you can see that it is edema. Yeah, you can see these little spaces all there, and there is very light colored material. So this is edema. Excellent. So this is seminiferous tubules. And here, what is this? And just look at the veins. They're stuffed.
Vein.
No, yeah, that's a vein. But what is this stuff? What is this? What do you think it is?
Duct of epididymis.
Yes, so it is part of the epididymis, but the epididymis doesn't look like this, no? So it is something that is where the rete is collecting and finally trying to get into the epididymis. All right, yes. Very good. Now, what do you see here?
Seminiferous tubules with necrotic material, and some of the basal layer of these tubules, some of the cells showing nucleus.
Yes.
So, and in the interstitium, you can see edema and lots of hemorrhage.
All right. Anybody wants to add anything to what Marshi said?
And then the germ cells look detached from the basement membrane.
The germ cells do what?
Look, the cells looks detached from the basement membrane.
Germ cells are detached from the basement membrane. Anybody else wants to say anything else?
Ma'am, in seminiferous tubules, some of the cells are the necrotic and some are the viable.
All right.
Viable germ cells. Yes, ma'am.
Can I ask you, is spermatogenesis, was spermatogenesis going on before whatever necrosis happened? Was there spermatogenesis or none?
Yes, ma'am.
What's the point of asking whether there was spermatogenesis or not?
To determine the age of.
To determine the age. And you had some question to answer. There were two parts to that question. Yes, one part of the question was how did this patient present, and what was the age of this individual, right? So we are all the time now asking this question to ourselves. Yes, so here is your epididymis. You see the columnar lining? Yeah, which is also a necrotic, and there is hemorrhage that is present.
In the interstitium.
Yes, in the interstitium. So there was edema and there was hemorrhage in the interstitium. Now tell me, what was your diagnosis?
Torsion of the testis.
Torsion of the testes. That is the diagnosis. No? That is the etiology of the diagnosis. It could be torsion of the testes. It could have been something else. I don't know. But what is the diagnosis? Anybody else?
Testicular infarction.
Yes, testicular infarction. Very good. What kind of infarction?
Hemorrhagic.
Hemorrhagic infarction, which tells you what? If you take infarction in general, what are the kinds of infarction? Do you have any kinds of infarction? You said hemorrhagic. Yes, it is. It is a morphological kind of infarction. But what causes infarction? That you can actually type infarction into some group.
Ischemic type of.
Well, all infarction is ischemic. Do you think that there can be non-ischemic infarction? What is ischemia? What is ischemia? I see lots of people writing ischemic, acute infarction of testicular tissue, ischemic, infarct. I want to know what, first of all, what is ischemia? And the second thing is, what is?
It's hypoxia.
Yes. Who was saying something? Yavi?
Cellular hypoxia.
Cellular hypoxia. Excellent. So that's what is ischemia. And if you've got infarction, it is cellular hypoxia taken to the ultimate degree, right? It causes necrosis. That's what infarction is. It is necrosis as a result of to the cellular hypoxia. So finished. The hypoxia is of anoxia. It becomes anoxia, right? And then the cell dies. So how do cells die from ischemia? What are the two ways in which they can die from ischemia? Have you heard of arterial ischemia and venous ischemia? Or arterial infarction and venous infarction? Yes. What's the difference? What's the difference? How is it that a vein which is taking away blood can cause hypoxia? How can you get hypoxia, that is, or anoxia or infarction from a venous source or etiology?
Because there will be stasis of blood in the.
Yes, excellent. And so see, what is happening is that there's nothing wrong with the arteries. The arteries are pushing in blood over there, but that blood is cannot be removed, and therefore there is no gaseous exchange that is happening at that level. So you get congestion, you get huge venous congestion. Why? Because the vein is blocked, the artery is pouring in blood, and so you get venous congestion at the level of the tissue. There is no gaseous exchange, and you get anoxia. Yes, and you get infarction. And because there is so much congestion, it is hemorrhagic, because then the blood vessels, the veins, the small veins will rupture, and you get a hemorrhagic infarction. Okay, and that usually happens with twisting or torsion, because when you have torsion, the artery is a thick-walled vessel, so that's not going to get occluded. What gets occluded first? What gets
veins?
Absolutely. And that's what you get as a result of this. So if you want to go through this whole thing, which we need not, we can just go next. Is this congenital or acquired? Acquired. Is it physiological or pathological?
Pathological.
Pathological. Is it neoplastic or non-neoplastic?
Non-neoplastic.
It's non-neoplastic. Yes, because you see this testicular tubules, spermatogenesis was there, loss of cellular definition, coagulative necrosis, and hemorrhage. So this has to be non-neoplastic. And then, what are those things that we have to choose from here? So what's your diagnosis? Yes.
Cell death.
Cell death.
But as a result of what?
Necrosis.
As a result of the cell death, as a result of necrosis.
As a result of ischemia.
Ischemia, thank you. But you see all the chapters in your Robbins over there. So which one will you pick? Vascular disorder. Yes. So that's what you have. It is, sorry, hemorrhagic infarction of the testes due to, obviously we know that this is a venous infarct, and it is a venous infarct because of torsion. So this patient had acute pain, swelling and tenderness in the scrotum, and it was in an adult male. So you could get from all of your observations and interpretation the actual diagnosis. All right, excellent, very good. Who's going to take the next one now? Who's taking case number 2? Yeah, next, come on, Yavi. This is very simple.
Case number 2. It's a
Yes.
63-year-old female aura, the one a left hip replacement. The
Yes.
female received for histopathological examination.
Yeah, the femoral head was received. Yes.
She was being treated for rheumatoid arthritis, affecting multiple joints, including both shoulder and knee joints.
Knee joints, yes.
She also had a similar condition for which she was using a non-allopathic skin medication for many years.
Many years. Okay, come on. Next, come on. Now this is simple and you just have to do this quickly.
The session show bony trabeculae, large bony trabeculae in the upper portion, and piece of bony trabeculae. And
yeah, you see, what did you say?
The session show piece of bony trabeculae.
You see you see bone. Okay, this is bone. Do you know what is the meaning of trabeculae? Trabeculae is the plural of trabeculum. So when do you use the word trabeculum? What is trabeculum? Do you know? Yahweh? Any one of them wants to tell him? Trabeculum is a wall.
Bar.
Okay? It is a wall. So when that wall is cut transversely, you see a portion of that wall. Okay, and you know, have you ever been in one of these? You've been to Jantar Mantar and those places. Do you see, when you look at it from the top, you see the wall, and you see inside there are other walls that are all there. There's a maze inside. So when we cut this transversely, we see walls. So you can't have a trabeculum if you have a huge thick portion of bone like this. All right. This is like cortical bone. It is compact bone. So compact bone cannot have trabeculae. It is cancellous bone, which we see in the medulla. Yes, that has trabeculae. When you get a bone marrow biopsy, you will see cancellous bone, and you can call that cancellous bone trabecular bone because it has trabeculae, and in between that you see spaces. No, we see the interstitium. Do you see any interstitium here in this particular thing? Do you see interstitium here anywhere? No. So this is compact or cortical bone. That much go for certain. Okay. Yes. Now, what is it that you're seeing here at the top? Come on, Yahweh. What are you seeing at the top here, which I have outlined? Is that
bone?
Is it bone, Yahweh? Come on. We were absolutely clear that this thing that I am seeing here is bone. Yeah, and we called it compact bone. What is this thing that we are seeing at the top over here? Is this bone? You know, when I've got a double line now, Yahweh, can you see it? Yahweh, can you see the double line over here?
Yes, I see.
So, what is that structure? Anybody?
It's
yes, say.
It's a dead bone.
It is dead bone. Okay, he says it's bone. Whether live or dead, I don't want to know. I want to know what it is. So come on now. What about you, Gunjan? What do you think it is? He says it's bone. And he thinks
It's
What do you
cartilage, a fragment of cartilage.
Okay, good. You're not asking me a question, you're telling me. You said it was cartilage. All right. What about you, Neelu? You have muted yourself, Neelu. What is it?
Ma'am, it's a cartilage.
It's cartilage. Yeah, Marshi.
No, it's cartilage.
Cartilage. All right. Now, which one of you is going to tell Yavi why you disagreed with him? Come on, you are the first person who said cartilage. Gunjan, tell him why you disagreed with him.
Ma'am, because we can see lacunae.
You can see lacunae. Yes, that
Cells are
doesn't make
present.
bone as well. You don't see
And
lacunae?
ma'am,
Yeah, you do. So?
yes, we see.
Okay.
Ma'am, there is differential staining of the matrix. So overall, this fragment of cartilage has abnormal pigmentation. It
Now I
has,
want to know why you're calling it cartilage.
and because the matrix overall has differential staining,
That's
the
why.
immediately around the lacunae is darker staining in comparison to the rest.
You have lacunae even in bone. No, all osteocytes sit in lacunae. So what is this lacunous stuff that you're telling me makes this cartilage? Come on, Neelam.
And on the edge, we can see an area of basophilic staining in the
Oh,
matrix.
that's why. So if my technician has stained it, peculiarly, then that is what we're going to say. Come on, Neelam, Neelu. Why did you call this cartilage? And lacunae, you just saying the word lacunae doesn't make it cartilage, yes? Marshi?
That is area of basophilic.
No. Do you know the size of the lacunae in cartilage and the size of the lacunae in bone?
The size of
Huge, just look at it. And not only that, you can actually see a cell, of course, in the middle of it. You see a nucleus, and you see this. It's a huge lacuna compared to what you would see in bone. Yeah, it is there so unevenly spaced over here. Okay, so this is cartilage and this is bone, but there is something that this is not dead cartilage. The cartilage is not dead because I can see a nucleus in each of those lacunae. So, but there is something wrong with this cartilage. And remember, this is an H&E section. What should cartilage look like in an H&E? Yes, come on, Yavi. What should it look like in an H&E section? What color should it look like, Yavi?
Yes, iron cartilage.
It should look like what color? What colors does cartilage take in an H&E section? You know what I'm asking?
It's yellow brown color.
Normal cartilage. What color is normal cartilage? Normal cartilage is what color? Yes, Neelam? Neelu?
basophilic, blue color. Basophilic.
It's basophilic, right? There's just a little tinge of basophilia that we are seeing over here. The rest of this cartilage is brown, no?
Brown.
Has a brownish pigmentation.
Actually, it's a khaki tinge, if you want to know. Yes, it's khaki, this particular cartilage. Yeah, okay. Let me just clear this. Now, what do you see here? What is this? Is it bone or is it cartilage? What is it, bone or cartilage?
It's cartilage. Right side is a cartilage.
Well, frankly, these osteocytes, these lacunae are quite large. And this thing is not blue, it's pink. So it's very hard, but I know that I've got a big part of which is either bone or cartilage, part of which is brown, and the other one is pink. To tell you the truth, I can't tell whether this is bone or cartilage. All I know is that there is something that has either a osseous or a chondromatous matrix, which part of which is very brown. Then that's the most interesting thing. Now here, what do you see here? Yeah. Can you make some observations?
There's a
What do you
bony
see?
fragment. It's a bony fragment, and
Bony
surrounding it is.
I don't think we know whether this is bone or cartilage, but it's something that you can say in this particular tissue that this, what is outside, is collagenous. Yes or no? I know that whatever is outside is collagenous.
Collagenous material.
Yes, this is all collagenous material that is outside. And I see some. Now describe what you are seeing here. Describe these shapes. Because if you describe them right, you have no other. First of all, we've seen that they're brown. And now you see these shapes. Look at these shapes. What does it look like to you? What is the shape?
Triangular.
Triangular?
Shards.
Yes, shards. They're like daggers almost, no? Just look at these dagger-shaped,
Dagger.
or the word that is used in the books is
Shard.
shard. What is the meaning of the word shard? Because we learn the word, but we won't know what it means. Yeah, look at these dagger-shaped things. And they are embedded in collagenous tissue. So what is this collagenous tissue in which all these shards are embedded? Look at them. You know what is a shard? Because somebody has
Like
got
a
the
fragment.
Yes, what is shard? What is shard?
It's like a fragment of broken glass.
That's right. So if you take a sheet of glass and you break it, it will break into multiple different bits, many of which are triangular, no? Like this. Imagine if this was a sheet of glass and it is broken. And it is obviously done that because this material, and it is usually cartilage, has become brittle, and so it breaks. And these pieces of cartilage, bone, whatever you want to call it, it's very difficult to know what it is, are embedded within what?
Bone.
What is all this cartilage? This pink material that is all around. What is this collagen? From where does it come? Can it be inside the bone? No. So where? Use your imagination. No, where does this collagen come from? Look at
Yes,
this
I know.
beautiful. You know that this is this bone or cartilage? Here you know for certain. This is cartilage. You see this? These two cells within a lacuna? See the huge lacunae? This is cartilage. And look at them. They're absolutely like daggers. And we call them shards, yes, because it's like when you break a pane of glass, you get this sharp pointed ends to it, okay? Whether it is like a dagger or it is like a triangle or it is like a rhomboid or whatever. But that's what you see over here. And it is embedded in what? Where would you get? Yes, in?
Synovium.
That's not, synovium is not collagenous. Synovium is not collagenous. So what is that stuff? It's the joint capsule, no? So this is affecting the capsules, and we know that this woman has had replacements. And now this is another joint that is being replaced, and it is replaced because there's destruction of the cartilage and the bone at the surface of the joints, and this is happening, and it's all, you can see the color, it is brownish, yellowish, black, khaki, and the word shard. So what is your diagnosis? There it is, the word shard. So what is your diagnosis? Anybody?
Ochronosis.
This is ochronosis. So this is acquired. Is it pathological?
Yes.
Pathological. Non-neoplastic.
Plastic or non-neoplastic? And what particular chapter will you find this in?
Metabolic disease.
Metabolic disease. Okay. This is ochronotic arthropathy. Okay, did you get that diagnosis, Yavi? Did you make that diagnosis, Yavi?
No.
No. Okay. So brown and yellow. See, when I asked you, what is the normal color of cartilage? Yeah, and if you had known the normal color, whether it is of bone or cartilage, if you have decalcified it cannot look brown, right? Yavi, it has to look either pink if it is bone, or it has to look blue if it is cartilage. Okay, and this was looking khaki, brown, black in some places. So if that observation had been made, then you will go to look up, no? Where do you get brown, black cartilage? So this was not a staining defect. This was real, okay? So this is ochronotic arthropathy, all right? And this is a rare metabolic disorder that is characterized by, brown, black pigmentation of connective tissue. And it's mainly bones and cartilage. And you get this pigment that causes darkening of the skin. You see it in the cartilage. If you go and take a biopsy of the cartilage in your ear, you'll find that is also brown. The sclera, okay, also turns brownish. Now, this is because of the accumulation, you can look it up, I don't want to give you a lecture on this, of homogentisic acid. But this patient did not have a congenital ochronosis, okay, which happens with alkaptonuria, when you have phenylalanine that is not being broken down. This lady was using for years and years of phenol complexes like hydroquinone, which are present in skin whitening creams. And this was what was being absorbed. And the silly lady has been using this. So those of you who want to use Fair and Lovely and all of this, please be aware that it contains phenolic compounds like hydroquinone, which can be absorbed, and your skin, which you want to get whiter, can become more pigmented, and you can end up like this lady getting problems with your joints. And she had joint replacement, spent so much money on, all happened as a result of this particular story. Okay, good. So who's going to take number 3? Come on, Neelu. No, you've muted yourself. Now you have to turn your...
Yes, ma'am. A 46-year female, right ovary in a known case of poorly differentiated squamous cell carcinoma of the cervix, for which a Vardine cystectomy was performed. The right ovary showed a 3 centimeter size cyst.
Very good. Excellent. Now come on.
Ma'am, this scanner view showing the presence of the cystic space, which are lined by the transitional stratified cells.
Excuse me, we are at low power and you're telling me transitional stratified cells.
Multi-layered stratified, multi-layering.
Right, so you saw a cyst and
Yes,
you can see the cyst wall, right?
Yes, ma'am.
Correct. Now tell me what you can make out about the cyst wall at this power. Anything that you can say about the cyst wall at this power?
Yes, ma'am.
I told you that low power gives you perspective. So what perspective have you got at this power about the cyst wall? Anybody else besides Neelu? We are all in this thing together. You see
There
things.
is a
Yes, Kunjan.
there is a multi-layered epithelial lining.
There's a multi-layered epithelial lining. Would you like to show me this multi-layered epithelial lining? You know how to. This is a whiteboard, so you can draw on it.
Like this.
You know how to do it?
Yes, ma'am.
That is it. Oh, the yellow thing. All right. Now you are telling me that this is the multi-layered lining. Would you consider this also a lining? Yes. There's one here also.
Yes, ma'am.
Yes or no?
Yes, ma'am.
Yes, ma'am.
Oh, yes. Okay. But and I assume that you're saying this is the multi-layering, right?
Yes, ma'am.
Right. Now you want to tell me what this? I mean, you're just what's that? I do see some some sort of lining. I do, and it is best appreciated over here. I know you went there; that is also there. But if you've got this, then what is underneath here? What is this?
There is a solid cellular area.
Solid cellular thing. All right. So at low power, I'm seeing a pattern. I see a cystic space. And it is a irregular cystic space, you know, because it's got so many of these little areas and like something that look like septi, but I don't know whether they're really septi. But you can see that there is a lining, and that lining has got two components, whether you like it or not. That there is a inner component. Right, and I'm drawing these two parallel lines. You can see that? Yes. Your also thing was the same thing. Look at it. It's a wavy thing. And it's got an, like that. Do you see this lining?
Yes,
And
ma'am.
then underneath that or deep to that, there is a solid component to this cyst wall. Yes. So there is an inner thing that looks like a wavy, or you may want to say scalloped in some parts, lining, and deep to that there is a solid portion. Am I making this up, or can everybody see it? You can see it, right? Yes. All right. Good. Now let's go to the next thing. Now you can see it. Look at it. Beautiful. You see this? And then there is a cleft-like space, and it has separated from something that is solid. Yes or no?
Yes, ma'am.
Okay, now, so who was doing this?
Yes,
Was it you doing this case? Yes. So come on.
Yes, ma'am.
So now you can see it at a little higher power. So now
Yes.
describe.
Ma'am, this power is showing the presence of the multi-layered epithelium, which is almost 6 to 22 layers in thickness, and with abundant mitosis also seen.
I can't say any mitosis at this level. If you want to see the mitosis, we better go to some other level. Yes.
Yes, ma'am.
Now you can see abundant mitosis. Yes, excellent.
Yes, ma'am. And this power is showing the presence of the tumor cells. These are the these cells are having hyperchromatic nuclei.
You can describe it. Yes.
Yes, ma'am. These cells having hyperchromatic nuclei, pleomorphic tumor cells, high NC ratio, hyperchromatic nuclei, and vesicular chromatin, and moderate amount of eosinophilic cytoplasm, and with abundant abnormal mitosis.
How we are supposed to describe cells? I told you what we see at high power, right? So how do we describe cells?
These are round to polygonal in shape.
Round to polygonal in shape. Now, what is round about this, I don't know. But you can see, no, each of these cells, you can see them, you can see a shape to the cells. Some of them are oval, some of them are polygonal, in other words. Yeah, so, but what do you see about these, the cells? I told you, no, when you look at this, you will have to say, are these monomorphic or are they not? Are these monomorphic or are they not? Then we can now go to shape, this, that. What?
They are not monomorphic.
They are not monomorphic. Now I'll take a poll from all the 4 people over here. She says that they are not monomorphic. Gunjan.
They are monomorphic.
They
if
are.
There is atypia, it's mild.
Okay.
Mild atypia.
If there is any aniso thing, it is very mild anisonucleosis or anisocytosis. Somebody has said, Maniza Ayub has agreed with pleomorphic. Annapurna says that it is, Lavanya says monomorphic. So there is a big discrepancy over here. So let me poll the other 2. Did you poll monomorphic or thing? You don't have to. It's
yes, we did actually.
And what did you get?
So 86% of the attendees think this is monomorphic, and 40% is going with polymorphic.
Because this is monomorphic, absolutely monomorphic. Okay, yes. So I didn't ask Marshi, if you want to be truthful, what did you think, monomorphic or pleomorphic?
I thought it was pleomorphic.
You thought it was pleomorphic. And what about Yavi?
I think it's monomorphic.
Monomorphic, excellent. Every nucleus is the same as every other, and there is really no variation in size or shape of these cells. Now, somebody, I think, what did Neelu say? Neelu said there are a lot of mitoses, and you said something about the anisonucleosis or the pleomorphism. And you said that these were tumor cells, right? Now, let me ask Gunjan, what did you think, tumor cells?
It is transitional type epithelium, which shows mild atypia and increased mitotic figures.
Because everybody is now calling this transitional epithelium. You're probably right. Yes. What about you, Marchi?
Yes, ma'am. Transitional
epithelium. What about Yavi?
I think it's material is
transitional epithelium. All right. Now let's go to the next thing. Okay. Same thing at higher power. All right. And again, you can see that it's monomorphic. Every one of these has got a nucleolus. Yes. Or it has, which is centrally placed, or maybe at the periphery, and the nuclei are nice and round. Now we go to this cleft-like space, okay? It's not actually a sharp space, but it seems to have separated from something that is deep to this. On this side, round nuclei, monomorphic. Now, what do we have in that, on the other side of that space? Come on, Neelu, you have to describe this. Is this, first of all, monomorphic? And does it resemble what is there on the other side? That is on the in my screen, it's on the right-hand side. And what you have to describe is on the left-hand side. So,
ma'am, it is not exactly monomorphic.
Okay.
Yes, ma'am. And some of them are oval in shape, and some of them are rounded.
Nuclei. Right?
Nuclei. Yes, ma'am. Yes, ma'am.
Yes. Some of them are spindly, some of them are oval, but most of them are round. Yes.
Yes, ma'am.
The nuclei are not as. I remember what I was going to ask Neelu, and anyway you can say. You said that they were hyperchromatic. The ones that were in that monomorphic area. Why did you call them hyperchromatic? What was hyper about it? Everything that you use, hyper, hypo, is in relationship to something, right? So it has to be normo in the middle, hyper on the high side, and hypo on the other. So how do you know what the normochrome should be over there that you called it hyper? Big problem, no? So you can only describe a nucleus. You can't say whether it is hyper or hypo unless you know what is normo, yes?
Yes,
You
ma'am.
can't say this is hyperchromatic or hypochromatic unless the nucleus is really very pale, and you don't know any nucleus that can be so pale anywhere. Okay, so then that's okay. You can say that this is very pale or very hypochromatic, but I don't think that you can say that this is hyperchromatic because you don't know what is normochromatic for that particular part. Okay. Okay,
Yes.
good. Now you tell me about this. Yes, oval, round, even some spindly. And what, anything else you notice? Are they all perfectly round apart from the oval?
Indentation.
There are
Indentation.
indentations. Just
Indentation.
notice that. Okay, you see this? See this
Yes, ma'am.
nucleus? It's grooved, and there are more than one that are grooved. Very interesting. There's some grooves over here in this particular. So it's different from something that you see on this side. Okay. You don't see any grooves that are present on that side. Yeah. Okay. Excellent. So anybody now has anything to say? See, look, this is that. There are some that are and you see more light pink cytoplasm. Not only do you see light pink cytoplasm, you see something else in the cytoplasm. What do you see? Do you see or not?
Microvesicles.
Now we see microvesicles. Very good, Neil. They have microvesicles, no? It's a microvesiculated cytoplasm. You can't see the cytoplasm model very clearly in all of it, but it's microvesicular. Yes. Good. So now the diagnosis. Shall we start? What is this? Congenital or acquired?
Acquired.
Acquired. Excellent. Physiological or pathological?
Pathological.
Pathological.
Excellent. Neoplastic or non-neoplastic?
Neoplastic.
Neoplastic.
All right. Is it benign or malignant?
Malignant.
Malignant. Sure? Malignant. All right. And if it is malignant, is it primary or secondary?
It is primary.
It is primary. All right. You said thing. According to you, it is primary. So what's your diagnosis?
Transitional cell carcinoma of ovary.
Transitional cell carcinoma of the ovary. Anybody else has a different diagnosis? Anybody? All of you reach the same diagnosis? Transitional cell carcinoma of the ovary? No, all right. Gunjan, what's your diagnosis?
And that these could be metastasis from the cervical squamous cell carcinoma,
Right.
along with
Yes.
an area of transitional epithelium,
All right. Okay. So
which could have arisen as a
metastatic squamous carcinoma. What about you, Marshi?
Transitional cell carcinoma.
Transitional cell carcinoma. And what about Yahweh?
I will give with differential.
Yes. What is your differential diagnosis?
Brana tumor.
What? Sorry.
Brana tumor. Malignant Brana tumor.
Malignant Brenner tumor. Okay.
Adult granulosa cell tumor. And differentiated carcinoma.
Which other tumor? Granulosa cell
Adult
tumor.
granulosa cell.
Adult granulosa cell tumor. Okay, somebody called Deepthi has said adult granulosa. Somebody, Meera Radhakrishnan has said Brenner. Fatima Miraj has said juvenile granulosa cell tumor. Rangoli Sadhna has said granulosa cell tumor. All right. All right. So we have these diagnoses: carcinoma, sarcoma, I don't know, sex cord, stromal tumor. Now, will somebody please tell me what was the history that was given to you about the ovary? Tell me.
There was a cystic space.
3
Yes.
3 centimeters
3
cyst.
centimeters
Cyst.
cystic space. Do you know how much is 3 centimeters? How much is 3 centimeters? As big as this that I'm showing you? Yes, that's 3 centimeters, right? 3 centimeters means 1.5. Sorry, how many inches? How many centimeters are there? 2.5, right? So it's a little over an inch in size. Okay, so you know how much is an inch, no? This much? Yes. Okay. Now you call that, somebody called it metastatic metastatic carcinoma. Somebody said that this was a transitional cell carcinoma. Somebody said that this was a malignant Brenner tumor, and almost everybody thought it was malignant. And somebody said these were sex stromal tumor. Now, here I have written the description, which I didn't get from you guys, okay? It is a cystic lesion with 2 layers in the wall. I showed you the 2 layers distinctly. Inner composed of medium-sized polygonal cells, pink cytoplasm, round nuclei, 1 or more small nuclei. Outer, more abundant cytoplasm, oval, pale nuclei, small nucleoli. And did you notice the stroma? And you can see it here, this bottom left-hand corner. Sinusoidal, and I didn't put it here, that there was a vacuolation and there is microvesiculation in that cytoplasm, which you guys yourself noticed, okay? And mitoses were very conspicuous. Now, suppose we ask the questions again. Is this congenital or acquired? What is it? Now everybody is stunned, no? Now we don't even know whether it is congenital or acquired. What? Is it congenital or acquired? Come on now, tell me. Of course it is acquired. Yeah. Now we come to the next thing. Is it physiological or pathological?
Pathological.
Pathological.
No, it is not. It is physiological. Now that I've told you it is physiological, please tell me what it is. It is physiological. And I know why you people got carried away and called it malignant, because there were mitoses. And you see mitoses and you think that it is malignant. So what is this? This is physiological. Now you tell me what is physiological in the ovary. And now that I've said it is physiological, I am getting all sorts of answers in the chat box.
Granules.
What? What is physiological in the ovary that is cystic? And that can reach the size of 3 centimeters.
Graphian follicle.
Arey Baba, you don't know about a developing follicle? You don't know that this is a follicular cyst?
Graphian follicle.
No, it is, yes, it is like, you call it a graphian follicle, whatever, it's a follicle, all right? And it has got an inner granulosa lining and an outer theca, and that theca is becoming luteinized. It has got microvesiculations, etc. Okay, so this is a developing follicular cyst of the ovary. And you guys called it malignant. Okay, so what lesson did you learn from this? You all learned a terrible lesson, no? And what's the lesson? That if we don't have, we have to make observations. You did not make the observation even when I told you that there are 2. You can see that there is a line, something that looks like a lining, and then what did you think was that area that was solid, that was different? Huh? So we are here to learn. As long as you have learned, and you do this in a systematic fashion, do not make up your mind. You know, saying, oh, I see lots of mitoses. Now, why are there lots of mitoses? Please tell me, why are there so many mitoses? Why?
Because it is dividing tissue.
Of course,
Dividing cells.
it is. The follicle is growing. The follicle can't grow unless it is making more cells. Okay, that's why we get numerous mitoses in a normal proliferating endometrium. Okay, and we don't look for anything else but mitoses in a proliferating endometrium. Normal proliferative phase. Mitoses in the stroma, mitoses, we call it proliferative endometrium. Yes or no? It's absolutely benign and it's absolutely physiological. And you can see here, you can see, look at this sinusoidal stroma. And even in that part where you were going on saying that this is multi-layered and this and that, absolute monomorphism. Not there's no pleomorphism, no anisonucleosis, nothing. Okay, but the moment you see mitoses, then you saw hyperchromasia, you saw pleomorphism, you saw everything that did not exist. Why? What's the reason you did not see it? Come on, you have to tell me. Because you did not look. You just saw the mitoses and your mind shut down. Finished. There was no need for any observation. Understood? So this you cannot do. It doesn't serve the purpose of making a diagnosis, and in this case, it would be a serious mistake. Okay, a really serious mistake. And I can tell you that you will never get these sort of things in your exams. Nobody's going to keep a developing follicle in the exam. But in the real world, I have seen more than one case of a developing follicle being misdiagnosed as all kinds of things, carcinomas, sarcomas, and all of that. And then patients come for a second opinion and all that they have is a developing follicle. So please be very careful. All right, now we have the last thing and we will finish. And this is the most easy thing in the world. So who's got the easy thing? It is Gunjan. Come on. What is this?
This is a 71-year-old female patient. Tissue from the right axilla.
Excellent. Okay. Now come on.
So here in this section, we can see a stratified squamous lining on one side.
Yes.
The underlying dermis appears to be collagenized. So in the deep dermis and the subcutis, we can see ill-defined hypo and hypocellular areas, along with 2 intact hair follicles. And a few glandular structures can also be seen in the lower right-hand corner.
All right.
The left corner.
That's okay. Now what do you see?
So in this section, we can see numerous glands and a hair follicle embedded in a stroma, which shows a dense inflammatory infiltrate, especially in the upper part of the section.
But what we can see is that you have hair follicles, yes, and the rest of it. What? You're saying there are glands, yes, but what do you think those glands are?
The stroma.
What are those glands? Now, yes, this is. Let's go to the previous. What do you think these glands are? Yeah, there are some glands. Yes.
Because this is the axilla, so they are likely to be apocrine glands.
Excellent. So we are seeing at nexa, right? So we are seeing this is skin because you're seeing hair follicles and you're seeing sweat glands. Okay, and in this case, the sweat gland happens to be an apocrine gland. Yeah, because it is the axilla. Very good. All right, so let's clear this.
And you can also see.
Yeah, what do you see here?
This is inflammatory infiltrate. I think that's all we can see.
An inflammatory infiltrate.
A dense inflammatory, perhaps. A highly cellular area, which.
What do you think are these inflammatory cells, as people call them? What are they? Now you can see this, no? Better. The same cells are seen In the
Yes, ma'am.
So they are neutrophils, right? And you've got a huge collection of neutrophils. So what is, when you get a collection of neutrophils, what is it?
An abscess.
Yeah. So the observation is a huge collection of neutrophils, and the interpretation is that you have an abscess, right? Yes. Okay. So there is an abscess, and what do you see here? Now you can see
And
those
here we can
glands.
see multiple. Yes, ma'am. So at a higher power, we can see multiple glands which are lined by a single layer of cuboidal to columnar cells with eosinophilic cytoplasm having a granular appearance and rounded nuclei. Several of the lining cells are forming apocrine snouts.
Yes.
And the glands are bound by an outer layer of myoepithelial cells. Aggregates of neutrophils can be seen within the lumina of the glands.
Yes.
And along with a few intraepithelial inflammatory cells as well. And the intervening stroma shows a dense inflammatory infiltrate, which is a mixed infiltrate composed of neutrophils, lymphocytes, histiocytes, and a few eosinophils.
Excellent. So what is this now? Anything that you want to add, subtract, or anything?
It's the same gland at a higher power.
Yes.
And I think we can see most of the same things.
Yeah.
Except for a few eosinophilic
suppuration within the glands, no? When you say abscess, you are talking about suppurative inflammation, no? That is what an abscess is about. So, and you've got this suppuration within these glands. So it is inside these glands as well as outside. Obviously, the glands have ruptured, and then there is an abscess that has gone elsewhere. So, what is your diagnosis now?
It is an acquired process.
Acquired process. Very good.
Pathological.
Very good.
Non-neoplastic.
All right. Now choose.
Acute inflammation.
Yes. Okay. Excellent. So what's the diagnosis?
It would be the early stage of hidradenitis suppurativa.
Early? It's a more than it is hidradenitis suppurativa.
It is hidradenitis suppurativa.
Yes, it is suppuration within. Why hidradenitis? What is hidradenitis? What does it mean? What is hydra? Whenever we use that prefix hydra, what is it? What is it? It means sweat, no? Anhydrosis means what? An inability to sweat.
To secrete.
Okay. So hyperhidrosis means that you sweat too much.
Excessive sweating.
Hyperhidrosis is people who keep sweating too much, and it's on their palms and soles. Like you guys were sweating at the last, the last case that we were discussing. Yes. Okay. So this is suppurative inflammation. Yes, acute suppurative inflammation occurring in a sweat gland, and this is a very common condition in people, particularly elderly people or very young babies and things of that sort. If they are sweating a lot and they are unable to clean or to have good hygiene, so you get it in the armpits, you get it near the groin, you get it in many different folds of the skin if patients who are fat, and that is hidradenitis suppurativa. All right, so thank you very much. You guys have been good. We come to the end of this this talk, and it says here, no? Cogito ergo sum. And the meaning of the word cogito is to think. That's why we talk about cognition. You've heard in neurosciences, cognition comes from this Latin word to think. So if your thoughts are confused or you're not able to think properly, then you have a cognitive disorder. So Now that is what Rene Descartes said. But Rene Descartes or anybody else, Anita Borges never leaves anything for the last word to anybody. So what is my last word? He said, I think, therefore I am. And Anita Borges says, I think because I must. So for all of you, please, if you are going to be good professionals, just begin to think. And to think is to ask why. Why? The what and the how, lots of people will tell you. Then you will be trained monkeys, and you don't want to be trained monkeys. Do you want to be a trained monkey? Does Marshi want to be a trained monkey? Answer is there's no yes answer. No. Huh? What about you, Yavi? You want to be a trained monkey? He's the only one who said he wanted to be educated. And I commend you for that. You want to be educated and not just trained. And the way that you will reach that goal is by thinking. Okay? I think because I must. All right. Thank you very much. We've gone over time. Gaurav, thank you so much for being patient and sitting here for 2 whole hours. I hope that everybody learned something from this, particularly from case number 3.
Yes.
Yes. All right. There were a few questions, and one person asked about case number 3. Why is this not a corpus luteum? It's not a corpus luteum because when you have a corpus luteum, first of all, that cyst should have had blood in it, because, and if it was beyond the blood stage, then you would not have had those regular double lining. You get just one big luteinized lining with no distinction between granulosa and theca. Here you have good distinction between granulosa and theca. Okay, so good. Thank you, all of you.
Thank
and
you,
have a good. I'm going to have a little spiritual refreshment. So you guys can either have spiritual refreshment or go and have your dinner. Thank you.
So just before we end, ma'am, we'll just let them know that this is the future slide seminars will continue on every first and third Monday of every month at 7 p.m. The next slide seminar we have scheduled is next week, when we'll host Dr. Mufaddal Munim. He's a consultant pathologist at London, United Kingdom, and he will speak on the approach to bone marrow biopsy, where 4 residents will go over the microscope with him.
Wonderful. Okay.
And our next talk, which is scheduled tomorrow. So today I think was a discussion of why. So tomorrow we will go to the how. So Dr. Mukesh Desai will speak on how a pathologist can suspect immune deficiency. So I hope to see you all tomorrow evening.
That's a lovely picture of Mukesh, I must say. Okay. Thank you.
Thank you.
All right.
Thank you, ma'am.
Thank you, ma'am.
All to the rest.
Okay.
Thank you, ma'am.